Good afternoon. Next speaker is Dr. Topoti Mukherjee. She is from Bangalore. She is a well-known nephrologist in Bangalore for a lot of good reasons.
Thank you.
She will be discussing about a common day-to-day problem, drug-induced hyperkalemia. I think it's one of the very common problems we face in the OPD. If it is an acute hyperkalemia, things are much easier. But if it is a chronic hyperkalemia, then things are not very clear. There are no very proper guidelines on this. I'm sure that Topoti will put some light on this aspect. Over to Topoti.
Thank you, Dr. Ishtiaq, for the kind introduction. And thank you, the organizing committee, for providing me with this opportunity. I'll be discussing this topic of management of hyperkalemia in patients on renin-angiotensin-aldosterone system blockade and other drugs. I declare that I have no competing financial interests or personal relationships that could have influenced this talk. I have received travel grants from the organizers. My objectives would be to dwell in the dilemma of RAAS blockade, their benefits and flaws, to talk about hyperkalemia, the risk, recurrence, incidence, etc., to talk about the management strategies, including the newer drugs, to visit the guidelines, and to talk about the unmet needs and future directions. So RAAS blockade is something as old as probably over a century, when renin was identified by Tiger, Stead, and Bergman as a vasopressor agent from renal extracts. And over the next 60 odd years in the same cascade, another substance with vasopressor effects called angiotensin was identified in different continents, Argentina and USA. And the scientists then arrived at the conclusion that there are two vasopressor agents in this cascade. And further down, aldosterone is also produced from the adrenal gland. And angiotensin 2 causes vasoconstriction, and aldosterone also causes sodium and water reabsorption, both of which contribute to hypertension. Now, the term cardiovascular renal continuum was coined by Zaus and Braunwald in 1991, basically to speculate that this particular system is responsible not only for hypertension but also cardiac and nephrotoxicity. It was identified over time that this particular system can cause atherosclerosis, myocardial infarction, cardiac dilatation, heart failure, and in the kidneys, endothelial dysfunction, micro and macroproteinuria. And finally, end-stage kidney disease. So therefore, it only was logical that drugs targeting this particular system had a therapeutic benefit in reducing hard cardiac and renal outcomes. However, this particular system, the drugs targeting this system also can cause hyperkalemia by reduced aldosterone secretion or increased aldosterone resistance. And that causes a frequent clinical conundrum for clinicians, whether to provide the patient with the benefits of this system or to avoid this or discontinue these therapies for fear of hyperkalemia. Hyperkalemia is one of the most common excuses for clinicians' failure to up-titrate the dose of these drugs. Potassium-rich diets are also consistent with dietary patterns that are considered healthy, and hyperkalemia for us as nephrologists, it may be indirectly associated with progression of cardiac or kidney disease because its finding often leads to down titration or discontinuation of these drugs. So how common is down titration? It's as common as 15 to 20%, and discontinuation of the drug is as common as 20 to 30%. Only 40 to 50% of deserving patients get the benefit of drugs targeting this particular system. And suboptimal or discontinuation of RAAS inhibitor therapy is associated with adverse outcomes or mortality in patients with CKD, heart failure, diabetes. It is also very interesting to note that every episode of hyperkalemia, the recurrence, the time interval between each successive episode only shortens over time. Now I'll talk a little bit about hyperkalemia. We know that it is potassium is mainly an intracellular cation. It is the second most abundant cation of the body. It is largely eliminated by the kidneys. In CKD, the intestinal excretion increases by some compensatory mechanisms. And we know there are some substances which cause transcellular shift of potassium. Hyperkalemia is, the true incidence is not known. It is around 2 to 3% in the general population, 1 to 10% among hospitalized patients. It is 2 to 3-fold higher in patients with risk factors like patients on RAAS inhibitors, CKD, heart failure, or diabetes. And just as we have several studies that support the use of RAAS inhibitors for cardiac protection, the same studies, all these studies report different incidences of hyperkalemia in patients on these drugs. There is a variable incidence in advanced CKD, and AKI, the prevalence is not known, but in ICU there are some numbers quoted based on no AKI and different stages of AKI. So the KDIGO mentions a frequency of hyperkalemia of 40 to 50% in CKD and heart failure, and 15 to 20% in diabetics and resistant hypertension. For obvious reasons, as the CKD stage progresses, the incidence of hyperkalemia also progresses. And this can be responsible for all-cause mortality, CKD progression, and hospitalization. And of course, these also have high cost implications. Now, talking of the management of hyperkalemia, the considerations we should think of are aggressiveness of therapy is directly related to its rapidity of development. One needs to exclude pseudo-hyperkalemia in these patients, whether it's a serum or potassium plasma sample. Point-of-care testing or a stat lab versus laboratory assessment. Usually, point-of-care testing is also reasonably accurate with a difference of 0.5 millimoles per liter. But it should be confirmed with the laboratory, especially in patients with unsuspected hyperkalemia. Of course, the background of the patient is to be considered, and different specialties have different interpretations, so that also can be taken into consideration at the back of our mind. We are aware of the drugs causing hyperkalemia, the renin-angiotensin-aldosterone system blocking drugs, which are the bone of contention today. But we must also have at the back of our minds some natural products, because it's very fashionable to take these products these days, and most of them have unsubstantiated claims to success, and that is something that we as clinicians should always have in our mind. The management of hyperkalemia, the principles include membrane stabilization, identify sources of ingestion, enhance transcellular uptake, and increase potassium excretion. Membrane stabilization, acute hyperkalemia is obtained by calcium gluconate or calcium carbonate, but calcium chloride. Calcium gluconate is more preferred because of its less cardiac toxicity. One has to simultaneously promote the transcellular shift of potassium with insulin glucose drip and salbutamol nebulizations. A calcium gluconate drip can be, injection can be repeated within 5 to 10 minutes. It acts within 1 to 3 minutes to prevent ventricular fibrillation. And all this has to be started immediately as a treatment of acute hyperkalemia. And this has to be monitored by the ECG changes. And the potassium has to be re-monitored within 1 and 2 hours, because there can be a rebound hyperkalemia in with these patients, because we are not really treating the cause of hyperkalemia. We are just acting immediately to prevent cardiac toxicity and to promote transcellular shift. Role of soda bicarbonate, it activates the sodium-potassium pump and causes intracellular shift of potassium. It is relevant in concomitant metabolic acidosis, and if the patient's volume permits the usage. Now, it's important to note that there is no cutoff for hyperkalemia, but it is convenient to say that any level above the normal level of the lab can be caused. Some people use 5.5, some people may use, nephrologists dealing with CKD may use a little higher cutoff of 5.8 or 6, but there is no definite cutoff. Now, neither of these measures promote potassium excretion, which is important. Diuresis is relevant in patients who have, especially those who are volume overloaded and patients with residual renal function. Dialysis if there is severe hyperkalemia that is refractory to the above measures, and potassium binding agents which promote the gut excretion of these of potassium. Now, sodium polystyrene sulfate is something which is being used for several years. It is a cation exchange resin. It is basically an insoluble polymer that resembles a crystalline lattice, which when placed in a solvent swells and allows exchange of the resin with ions. So this is actually, it is used for several years with some favorable results. It is used orally or as an enema. It is non-selective. It doesn't bind just potassium. It also binds calcium and magnesium, and therefore it can cause hypocalcemia and hypomagnesemia. Its in vitro binding capacity is much higher, and in vivo is much lower, probably because of the concomitant binding of other ions. This particular drug has, in spite of its beneficial effects and a lot of data supporting its use, it has been scrutinized because of its occurrence, the occurrence of colonic necrosis, which actually used to happen with co-administration of sorbitol. So in 2009, the FDA issued a warning against co-administration of sorbitol because of the harm of colonic necrosis, which is a rare but serious adverse effect. Other drug interactions include with antacids, digoxin, lithium, thyroxine. Other side effects include constipation, diarrhea, sodium loading. Not much data available in pregnancy or pediatrics, wherein we have to focus on the measures like calcium gluconate or membrane stabilization and transcellular shift. There's another preparation called calcium polystyrene sulfonate, which is more or less similar in action to sodium polystyrene sulfonate. Now, there has been a constant need for newer drugs, and the newer drugs include patriumor and zirconium. After the results of the Amethyst trial, which was published in 2015, which included mainly diabetic nephropathy patients with RAAS inhibition and with a GFR of 15 to 60 ml per minute, it was shown that patriumor at a dose of between 4.2 to 16.8 grams twice a day resulted in a significant reduction in serum potassium after 4 weeks, which was maintained over the next 52 weeks, and this permitted the co-administration of optimal doses of RAAS inhibitors. So patriumor is an orally administered high-capacity polymer that exchanges calcium for potassium as it moves through the gut. It primarily acts on the distal colon. It is non-absorbable. It causes a dose-dependent increase in fecal excretion. It is tasteless, odorless. Some interactions are reported. It is advised to administer the other drugs 6 hours before or after the dose of patriumor. Now, this was a trial which showed a favorable effect of patriumor when co-administered with spironolactone. There are several other trials which I'll not get into the details of. This is a trial called Diamond trial, which was a trial in heart failure patients with a eGFR of more than 30 ml per minute. And this particular trial also showed that patriumor favored the co-administration of RAAS blockade and other drugs, and enabled the physician to confer the adequate cardiovascular or renal protection required or desired. Some more trials on patriumor. Then there's another binder called sodium zirconium cyclosilicate, which is an inorganic sodium potassium cation exchange resin. It is more selective compared to the previous binders we discussed. It is orally administered, not absorbable, and it is eliminated in the feces. It selectively filters potassium ions via the same mechanism used by physiological potassium channels. The micropores on the structure have diameters similar to potassium. So therefore, zirconium does not capture any other ions. So it is more selective. Another advantage of zirconium is that its onset of action is faster. It's around within 1 hour after a 10-gram dose. There was a trial called Harmonized trial, which said that in the first 48 hours, a dose of 10-gram TID reduced the potassium to significant levels, and after that, the patient can be maintained on a once-a-day dose. Not many drug interactions have been reported. It's available as a powder with a full meal. And these are some trials favoring the use of zirconium. This is the trial showing that it causes a drop in the potassium after 48 hours. This was published in the CJSN, which says that this zirconium causes a eukalemic phase in a maintenance dose that causes over a 12-month study. It achieved eukalemia when co-administered with these drugs. So the differences between the binders are mainly in terms of their cation selectivity and onset of action and safety profile. So zirconium is more selective. It has a more rapid onset of action. Patrioma is less selective and acts after 7 hours, and sodium polystyrene sulfonate, although it acts in 2 hours, there are concerns of colonic necrosis, which the reported incidence is around 0.14% and along with sorbitol, but it has a worse side effect profile as compared to the newer drugs. Other modes of treatment, role of fludrocortisone, it eliminates potassium by renal excretion, and it is helpful in hyporeninemic hypoaldosteronism in solid organ transplant recipients on calcineurin inhibitors. Dialysis, as we discussed. Surgery, there's no direct role, but indirectly in cases of ischemic gut or tumor debulking whenever it is required. So there's no direct role. Role of diet. Now, diet is a hotly debatable topic here because it is something that is not often sustainable, but a low potassium diet of 2 to 3 grams a day should be administered in patients with chronic hyperkalemia. And here is the role of a nutritionist, renal nutritionist, that is very important. The renal nutritionist is expected to not just give a blanket diet chart, but to negotiate the diet, to renegotiate the diet, fitting into the socio-cultural, habitual preferences of the patients within the given dietary limitations. So this is just an algorithm. It has to be monitored by the ECG changes, the severity. In acute hyperkalemia, we have to promote membrane stabilization, transcellular shift, and then if continues to be refractory, offer dialysis, diuretics. There is no role known about potassium binders in acute hyperkalemia. In chronic hyperkalemia, there is a higher role of binders, and there is more data available on binders. One has to keep re-looking at the drugs that the patient is taking, and one has to keep managing the RAAS inhibitor therapy. What do the guidelines say? The frequency of monitoring of the potassium after every change in the dose of the RAAS inhibitor, one should monitor the potassium after 1 week of increasing the dose or introducing the drug. Guidelines, every body has a different guideline, so at the end of the day, the physician's discretion is always important. The American College of Cardiology uses a cutoff of 5, above which they use ACE inhibitors or ARBs with caution. The Canadian Cardiovascular Society is a little more liberal in terms of the potassium margin that they use. So between 5 to 5.5, they do not usually stop the drug. If the patient is already on the drug, they monitor the potassium closely and try to optimize the dosage. If the potassium is between 5.6 and 5.9, one does not start the therapy or reinitiate, but one looks at the concomitant drugs, considers the administration of binders, and once the potassium is within this range of less than 5.5, one tries to reintroduce the drug. The KDIGO does not specify an outcome. They assess the GFR and then consider starting the drug. National Institute of Health and Care Excellence, above 5, they do not initiate the therapy, and above 6, they advise discontinuing therapy. European Society of Cardiology, if the patient's potassium is between 4.5 and 5, and if the patient is not taking optimally prescribed doses of RAAS inhibitor, then one can up-titrate the dose and monitor the potassium closely. If the potassium is between 5 to 6.5 and if receiving optimal doses, then one only monitors the potassium closely, or adds a binder if required. And if the patient is above 6.5, one discontinues the drug totally. Now, just to summarize the guidelines and an approach to patients at risk for hyperkalemia caused by these drugs of inhibiting this particular system. Estimate the GFR. Whenever possible, discontinue drugs that may contribute to hyperkalemia. Prescribe a low potassium diet. Prescribe thiazides or loop diuretics if the GFR is less than 30. Prescribe sodium bicarbonate if there is concomitant metabolic acidosis. Initiate therapy with low-dose ACE inhibitor or ARB and keep monitoring the potassium. Measure potassium 1 week after initiating therapy or after increasing the dose. If the potassium increases to less than above 5.5, decrease the dose of the drug. And if the patient is taking one of the two drugs, one can decrease one of the drugs or reduce the dose of the drug. The dose of spironolactone should not exceed 25 milligram per day, and if the potassium is more than 5.5 despite these measures, one should discontinue the drugs. What are the unmet needs? Alternatives to RAAS inhibitors are few and of unclear benefit. There are adherence issues with a low potassium diet. A significant majority of patients do not become hyperkalemic on re-challenging the drug. So are we treating prematurely or are we over-treating them? There are no definitions for or cutoff for acute or chronic hyperkalemia. Natriuretic response to loop diuretics is limited. Role of binders, we are not sure in acute hyper. So it always has to be individualized.
Ma'am,
Sorry?
attention please.
Yeah.
Your
Please
time is up.
sum up, please. Last slide.
Okay, last slide. So the future directions, is there a role for newer binders, which we discussed, SGLT2 inhibitors and Finrenon? They may have some role in future. We do not know. So this is the concluding slide, that hyperkalemia is common, recurrence is common. We know that RAAS inhibitors do confer protection. ECG is the mainstay. Look at natural products. Frequent re-evaluation is important. And yeah, this is just the...
Thank you, Dr. Topoti,
Yeah.
for your elaborated talk on hyperkalemia with ACE inhibitor. It's a very practical problem, and it's good that you or organizer choose this topic. I would like to just say that when you are using ACE inhibitor ARB on CKD patient, you know there is in CKD there is a mechanism by which there is an adaptation to the colon, that the colon secretes more potassium. So any patient who is a CKD should be advised not to have constipation or to treat the constipation as early as possible, because that increases the potassium level. So this is the natural adaptation. The second thing is that when we are choosing a diuretics to treat CKD patients, if you are using ACE inhibitor ARB, I would suggest that it is preferable to use the furosemide rather than other diuretics like torsemide, because furosemide removes the potassium from the body. And many a times, particularly in diabetic CKD, there may be associated renal tubular acidosis, and there can be hyperkalemia disproportionate to the GFR. So monitoring the bicarbonate is equally important, and correcting the bicarbonate to prevent the hyperkalemia when you are using ACE inhibitor ARB in CKD is equally important. So these are the few points which I wanted to mention, that which is tips to prevent the hyperkalemia on CKD with RAAS inhibitor. Now the topic is open for comments and questions. Please. If you have anything. So anybody, any other person's experience about because we see that most of the time nephrologists tend to be reluctant to use the ACE inhibitor ARB if the creat is more than 3 or 4.
There was a study, that STOP ACE trial, which followed up patients for 3 years, and that showed that stopping in stage 4 slowed the progression. So that was another confounding study, and a reason for nephrologists to probably not use or down titrate the dose of RAAS inhibitors.
Yeah, stage 4.
Yeah.
Maybe, but there are many studies which have shown that it
True,
is
true, absolutely.
See, we are not talking about only the renal benefit.
There's a cardiac benefit.
The other system benefit, because this drug prevents a lot of diseases, including the strokes.
Absolutely.
It's a wonderful drug if there's a concomitant heart failure. So the management of hyperkalemia should go side by side when you are using this drug.
Absolutely.
Yeah. All
Thank
comment,
you.
please.
Yeah.
Thank you, sir. I request the chairperson to honor Dr. Topoti Mukherjee. I call upon
I
the
think
next.
just 10 seconds, the gentleman is standing. Please allow that for the 10 seconds. Yeah.
Yeah.
Please. Sir.
I am from Dr. Mani's school. So we use very high doses of ACE inhibitors in controlling the glomerulonephritis of IgA, diabetes, ADPKD, all those things. The only safety mechanism we adopt is we go by small increments.
Yeah, true, sir, true. Anything, any
Yeah,
other points? Sir?
2.5 to, we take 1 month
Yeah, yeah.
to escalate,
Slow
so
escalation.
that there will be adaptation to
Yes,
that level.
any other point to make, sir?
That's all.
Yeah, thank you, your point
Thank
is
you.
well appreciated. So we close this session here.
Thank you,
very
sir.
much.
The chairperson will